Hello, my dear audience, and welcome to another episode of Let's Talk Micro. As always, I am so happy that you are here with me. And if this is the first time that you're listening to Let's Talk Micro, well, thank you for choosing it as one of your podcasts. I am so happy that you're here. And if you're tuning in because you want to learn more about diabetic wound cultures, well, this is the episode for you, and we're going to be jumping into it in just a minute. But this was such a great episode, and I enjoyed it. And, it was good learning about how diabetes, impairs wound healing, the types of organisms that we can see. And something that is so important as those of us that work in the bench, sometimes you see so many organisms. So making those decisions about what do we need to work up, what can we mix, So in the episode, we talk about the guidelines. So as I like to say, all in all, such a great episode. So let's go ahead and jump into it. Okay, well, we know on the working on the bench, we see different types of cultures, and sometimes some of them, can get a little complicated, and we think about what working up and not working up. We also know about diabetes, right, and the effects that it has on the health. So I saw from the first course, first course symposium, that I talked about in the podcast before, and I saw this presentation about diabetic wound cultures, and I thought it would be a good topic for the audience. So with me today, I have a guest. He was the one that did the presentation, and his name is Christopher Doern. Dr. Doern, welcome to Let's Talk Micro.
Thank you very much. It's a pleasure to be here.
Pleasure having you. Thank you so much for accepting my invitation. So let's start with a quick introduction about what you do and anything else that you want to share with the audience.
Yeah, sure. So my name's Chris Doern. As we said, I'm a director of microbiology at VCU Health, Virginia Commonwealth University Health in Richmond, Virginia. I've been doing this for a little while now, maybe 10, 15 years or so. Before here, I was the director at Children's Medical Center at Dallas, which is a freestanding pediatric hospital, which is where I developed a first love of pediatric microbiology. And now I get to take care of both adults and pediatrics here at VCU. And yeah, before that, it did some training in St. Louis and undergrad and graduate work at Wake Forest. I'm pleased to be here.
Well, thank you again for coming, and so we'll be focusing on this episode on the microbiology of it all. But let's start with some general things, and we know that we see this culture from these patients that the wounds they don't heal, and we see like this repeat cultures with many organisms. So maybe we can start with talking about some ways in which diabetes affects and impairs wound healing.
Yeah, it's a good place to start because these are very different wounds. And I think that's something we all struggle with in microbiology is we call it the wounds bench, right? And then not all wounds are created equal. They're very different, and that's most true maybe of the diabetic foot ulcer. Really, is the majority of what we're talking about here. And there's a couple of things, and I assume we'll get into them as we go along that really impact both the microbiology and the treatment and response to that treatment. But generally speaking, the pathophysiology of the wound is very different. Diabetic patients are hyperglycemic, and that has a number of downstream consequences for the wound. So these patients develop atherosclerosis, which prevents circulating nutrients from reaching the wound and impairs healing. They also have a variety of different forms of neuropathy, both autonomic and motor. So there's some sweat gland malfunction or poor function there, which leads to dry and cracked skin, again, predisposing to infection. There's motor neuropathy, which increases the pressure on the plantar surface, which is where we see a lot of these wounds developing. These wounds are hypoxic that due to poor circulation, and that's something we can talk a little bit about, what the impact of that is on antimicrobial therapy. And there's a variety of other things. One of the ones that I think is sort of interesting that most probably don't appreciate is that there are sort of skin antimicrobial peptides. And those are also, the function of those are impaired in the diabetic wound, again, sort of breaking down those barriers and predisposing these patients to to infection and poor healing.
Okay, and one thing we know is that depending on the area of the body, right? The microbiota, is different and it changes, and we see a lot of studies out there depending on things like like your diet and medications and things like that. So when it comes to diabetes, how does that affect the bacterial diversity of the skin?
Yeah, there's a lot of different directions we can go with that answer. To start, just in terms of skin colonization, sort of outside the wound, maybe we do see a difference in flora in those patients, and it's what you see. it's almost like it's a dysbiosis where you just like you might get in the gut where the shift in pathogen distribution or organism distribution tilts more toward bugs that are tend to be more pathogenic. And so we do see patients that are diabetic with increased concentrations or increased percentages of colonization with things like Staph aureus, Pseudomonas, the Enterobacterales. You do still see skin flora, but these are organisms that are going to be more likely to colonize those patients than in an otherwise healthy patient there. So, and we can get into the microbiology, I assume, of the wounds and what that looks like too. But just to answer your general question about what the skin colonization looks like, it does tilt more towards bugs that have a predilection for pathogenesis.
Okay, and obviously, we tend to see when something is infected, but maybe we can talk a little bit about some signs of infection.
Sure, yeah, and this is, I think, something that's murky for us on the culture side, but also pretty murky for our clinician colleagues who are trying to assess whether or not these are true infections. So a couple ways to go there. So first, there is a grading system for the diabetic foot ulcer, and there's on a scale. There's mild, moderate, and severe infection, and the criteria around those things are more or less the following. So for the mild infections, one stratifying characteristic is the amount of erythema or redness that you have. So in a mild infection, these are infections that have a little bit of erythema, but not a lot. These patients don't have systemic signs of inflammation. They don't have fever. They do have some pain, a little bit of purulent discharge maybe, but generally speaking, these aren't deep-seated infections. So that's sort of your mild infection. And just as a precursor, this is going to have some pretty interesting impacts on what kinds of wound cultures we're going to get out of these, which we'll talk about. But then you have a moderate infection, and so this is a progression. Obviously, there's more erythema, greater than 2 centimeters. You do start to see some deeper involvement, but typically no systemic inflammatory signs. So you've got a deeper infection, but you're not progressing to systemic infection. And then severe infections, you have now you're starting to get fever, you're starting to get a leukocytosis. Your respiratory rate is up, your heart rate is up. So now you're progressing to a more serious infection there. And so this is the gradient. And then when you look at the things that we typically think of for a wound assessment, so it's redness, it's warmth, it's induration, pain and tenderness. But these are challenging things because these can be blunted in the diabetic patient. So I mentioned neuropathy. Well, you don't feel pain as well when you have neuropathy, and so some of the symptoms can be blunted there in terms of pain. Only a minority of patients will have any kind of change in white blood cells, so that's not a very good marker. So CBC is not very accurate. Same thing with some of our other markers that we lean on, ESR, CRP. These are thought to be pretty inaccurate in terms of assessing whether or not somebody has a true infection in a diabetic situation.
Perfect, and and we're gonna jump into the microbiology. We'll talk about samples and things. So, kind of just to close the loop a little thing, on the microbiome, because I know that in your presentation you mentioned, right, like a study that was performed in England, talking about the microbiome of the diabetic wound. Maybe you can talk a little bit more about that and what the findings were.
Yeah, and this will be a nice segue into the microbiology of it. This is a great study. And let me back up a little bit before we get to that and talk about some older work that had been done pre advent of next generation sequencing for microbiome analyses. So if you look back in the 70s, 80s, 90s, even into the 2000s, a lot of the culture-based microbiology, looking at the epidemiology of the diabetic wound, identified Staph aureus, anaerobes, some Enterococcus, maybe a little Pseudomonas. So pretty standard um, bugs there. But when we get to the study you mentioned, really, really nice study done out of England, as you mentioned. I believe it was 2017 or thereabouts. What they did, I think they took about 40 patients, maybe a little less than that, and these are newer patients to their care for their diabetic wounds, and they did a biopsy of the wound, so the highest quality specimen you can get, and they did a microbiome analysis of these patients here, and the pie chart of organisms that they found in these wounds, and these are patients with they think real infections, and we can talk later maybe about some of the analyses they did on the severity of those wounds and how they responded to treatment. But the general microbiology they found was a little surprising to me. So if you'd asked me what a diabetic wound would have been, we definitely see a lot of Staph aureus, see a lot of junk, frankly, a lot. And then we can talk about the microbiology around that at the end, I think, with some examples. We get a lot of what looks like intestinal flora, a lot of group B strep, um, and some anaerobes. And they saw all that in their analyses, but the distribution was a little bit more skewed towards anaerobes than maybe I would have expected. They even had a little Haemophilus there, which is not something I typically think of as a wound infector, probably there just as a colonizer. Some Acinetobacter, and certainly they saw the Staph aureus. But a big part of that pie chart was anaerobes and coag-negative staph, and which I thought was a little interesting. Certainly some common pathogens in there too, but basically it's what we all know. There's all kinds of organisms that they pulled out of there.
Yeah, and I will ask you more definitely about that, but those cultures, yeah, we can see like a lot of things in there. They can get very messy when we're working up, which is one of the things that we'll be talking about. So right for in the lab, right? So we're gonna set up a culture, so we need a specimen. So what are the preferred specimens for this type of cultures?
Yeah, really important, and we get a wide variety of things here. So at the top of the priority list would be that biopsy specimen, preferably from a clean margin or from a debrided area. So you're getting truly infected tissue. So either a bone biopsy or a tissue biopsy after something's been debrided. That's the best. The swabs, which we all get, they're low hassle to the patient. I guess you'd say they're highly convenient specimen to get. Those are minimally useful. You're picking up probably a lot of contamination or colonization. That's something we didn't talk about at the beginning, but when we think about defining infection, we don't really know in the lab. Is something infected, or is it some of the other possibilities? Is it just a wound contaminated, in which case the organism's just there, it's not replicating, it's not doing any damage, or almost the same, is it just colonized? In which case the organism is probably replicating, but it's not doing any damage, it's not causing a problem. We don't really know what we're getting when we get a specimen, and so that's where the swab is problematic because it could be any of those things. Whereas if you're getting a biopsy, you're much more likely to get something that probably is an invading organism, probably much more likely to be causing a problem. All right, so that's the main specimens. The thing that we get, and I would guess it's not just us, but we also get just severed appendages or amputated toes, and sometimes a whole foot will show up in the lab. And it's just something I would say to the audience as a cautionary tale. Like, rarely are those things indicated for culture. Usually they're meant for anatomic pathology because they're looking to do some sort of pathology on those as opposed to sending them to micro. And I'll say in our lab, they get a real kick out of calling me. I'm pretty sure I hear about 100% of the ones that come to the lab because I don't like toes and things, and so I get to look at all of those because I know it it drives me nuts. But really, those are ones that I would just say to folks that have those. There's no way to culture a foot if it shows up to the lab. My advice would be to reach out to the provider who sent it to you and say, "Did you really mean this to come to micro?" And almost always they didn't. And if they did, they can probably help you provide some guidance as to what part of that they're looking to culture and what that might look like, because that can be a little challenging.
Yeah, definitely. We get those in my lab too sometimes, and so by now we have touched a little bit on organisms and things like that. Maybe we can start with some examples. I mean, you have mentioned like Staph aureus, and that we see things like Group B strep. So can you give some other examples of pathogens that are seen in diabetic wound infections?
Yeah, yeah, and let me go back to that study you mentioned from England, if you don't mind, because they had some really, I think, surprising findings around the microbiology of the wounds. And so, one of the things they did is they went back to that scale I mentioned, for severe, moderate, or mild infections, and they looked at the microbiology around this. And they found some interesting things that I think most of us wouldn't have expected. So they found in their mild infections, those patients typically where the wound had been present for a shorter period of time, they found that the microbiology of those wound specimens looked a heck of a lot like every other wound specimen we typically get in in the microlab, or the ones that have real infections. So a clear predominance of a clear pathogen. So let's just say abundant growth of a Pseudomonas aeruginosa or a Staph aureus, maybe a little skin flora, but you've got a clear expansion of one organism. So pretty typical of what a classic wound infection might look like. And then they had another group. So your greater than 6-month wounds, some of your severe infections. Now, in my mind, I'm thinking, okay, you've got a severe infection. Those are the ones where you're going to have that like slam dunk diagnostic microbiology. You're going to have a bunch of Staph aureus or Pseudomonas. Wasn't the case at all. These chronic wounds were a mess. They had all kinds of organisms, not a clear predominance of anything. The one thing that they found consistently across those was a bunch of anaerobes. So those are a pretty consistent finding. But in terms of what we think of as a conventional diagnostic culture result, they didn't see that. So I thought that was kind of interesting. Um, and again, when they looked at what kind of organisms they were getting for some of these predominant pathogens, it was the things that we typically think of. It was a predominance of Staph aureus, some Pseudomonas aeruginosa, and that was it. They also looked at the treatment of those wounds, and I think we'll probably get into that a little bit later too. But when they looked at the treatment of these wounds, they found a couple of interesting things and something I didn't expect. So one of the things that's always been remarkable to me about the diabetic wound is how much group B strep they find in those. I don't think of that as your classic wound pathogen, but we see it in a lot of our wound cultures, and they saw that in their microbiome analyses too. And when you look at the response to treatment in this cohort of 38 patients, and this has been replicated in other studies too, the failure rate for treatment is very, very high. So somewhere in the neighborhood of 40%, in some studies, 80% failure rate of treatment, which really begs the question, are these truly infected wounds or is the organism just there hanging out? So I think that's a big question here. But one of the things they look for is, well, what organism correlates with treatment failure? Now, of course, you would think, well, it's going to be the multi-drug resistant thing. It's going to be that nasty Acinetobacter or multi-drug resistant Pseudomonas. And it wasn't. It was group B strep, probably the most treatable organism from an antimicrobial standpoint that we get. And so that again, I think, leads to this conceptual question of, is this really an infection? And I think we can probably talk about the true utility of culture and what culture means for the treatment of a patient. But that to me suggests that a good number of these probably represent something other than just pathogen causing wound, and that their outcomes are due to other factors, probably host factors, most importantly. So, and I'm sorry, you asked me about some examples. I can get into some examples now, but it might be helpful to talk a little bit more about sort of the workup of cultures before we do that, if that would be okay with you.
Yeah, yeah, of course. And actually, I wanted to start with first with the gram stain because I know you mentioned the predictive value of the gram stain alone, and this is something that I mentioned before on the podcast, and we do have our challenges when it comes to gram stains and cultures. That they're not always correlating with many factors, like they don't match. You see, like NOS, and then you have like a plate full of things, and so. But you do mention, the predictive value of it. So can you talk more about that? And you also mentioned a study and some results.
Yeah, sure. And yeah, the gram stain is the backbone of all microbiology, of course, and we do a lot of it. And one of the challenges with it is, as you alluded to, it's just not all that reproducible. And so using it as an absolute to predict things, we're going to have some things where either just through sampling bias, we're looking at the wrong thing, or if you had four different people reading a gram. We did this study in our lab a while ago and found that if you have four different people reading a gram stain, you get four different results. And so there's that begs the question, what's the source of truth, or what's the real result there? So not surprising that we sometimes see things like you mentioned there where they don't always line up with the culture results. But there are a few studies that look at this. So I think if you ask most microbiologists, well, what's the limit of detection for a gram stain? Most would come up with a number around 10 to the fifth organism. That's pretty conventional teaching around this. So anything less than that, you're probably not going to see it on gram stain. And there was a study done where they did this. It's an old study back in the 70s. And I should say I'm a little bit of a nerd for older literature there, going back to see, these foundational studies that often are really elegant in their simplicity. And this is one of them, the things that shape how we do things. And it was a simple study. They did a roll swab, so a little limitation there, but they did a nice cleaning debridement of a wound, and then they did a roll swab, and they did two things. They did a gram stain, and they did a quantitative culture, and they looked at the correlation between the amount of organism and the types of organisms they saw and the amount of organism that was grown. They saw a pretty good correlation between what they saw and what they grew. And the other thing that was interesting, and I think this is in part where the 10 to the fifth number comes from, is if you cultured less than 10 to the fifth organisms, there wasn't a single example. And there were a number of patients in this category where they didn't see any, they grew nothing. Or I'm sorry, they didn't see anything, but they grew less than 10 to the fifth organisms. And so that dividing line was a pretty good predictor. If you had more organisms than that on your culture, you generally saw it. Okay, so that's one study, kind of neat, looks at the quantitation. Roughly speaking, it correlates. That other study was done specifically for diabetic patients in a resource limited area. I think it was Tanzania. where they wanted to see, well, we don't have culture techniques, but what does gram stain mean? Can that be predictive roughly of what we should treat with? And they had a number of patients, 120 or so patients, and they did gram stains. About half of them, a little more than half, were polymicrobic, so probably a pretty good representation of our microbiology. And they looked at the gram stain correlation with culture, and it's written in a little bit of a funny way, so I don't want to get carried away with their conclusions, but they generally saw a greater than 90% correlation with culture results and gram stain, just in terms of morphology, gram negatives, gram positives. Few disclaimers to that. It was a gram negative heavy study, and they found something that surprised me. If you were to ask me in the context of a wound, are we more accurate to find gram negatives or gram positives with gram stain? I would have said gram positives all day long. They just sort of jump out at you in the context of, probably a red background. They found a slightly more accurate gram stain for the gram negatives. So don't know what to do with that, but they did find a greater than 90% correlation with culture results. So pretty encouraging for something that we spend a heck of a lot of time doing. So um, yeah, those two studies, and it's I love the simplicity of these kinds of studies. It's a simple question, right? Like, what does a gram stain mean for a diabetic culture? And I wish we did more of that kind of science, because um, that's where all the questions are for us on the bench. These very fundamental questions, and so those two studies speak to that, I think, pretty nicely.
Great. So let's talk about the right. So by now we have mentioned many times, there's a variety of organisms, and in these cultures you can easily find, as you say, you group B strep, you can find, Staph aureus. Sometimes, we see two or three enterobacterialis easily, and then on the mix, you also see and have seen, some like non-fermenting gram-negative rods. So, we do have guidelines, and working them up can be overwhelming, especially, sometimes the decision to, let's say, okay, well, would mix this or mix that, and sometimes techs on the bench, they can struggle with that concept of, but it's there, right? We're not gonna mention it. We're just gonna lump it into something. We're gonna mix it. Um, so maybe you can, talk about this and provide some examples of what to work up as far as, IDs and susceptibilities and reporting.
Yeah, sure. This is the question, right? After all we've talked about here, that's what we need, is that kind of guidance. And my colleague, Dr. Alexander Bryson, and I had the privilege of getting to revise the Clinical Microbiology Procedures Handbook wound chapter. And I have a habit of saying yes to things before I really think about it. And this is a good example of that. I had no idea how hard that was going to be. It's a heck of a thing. It's one thing to develop protocol for your own laboratory. Of course, you want that to be the perfect procedure and everything, and that goes with its own set of pressures. It's a whole other to think about a procedure that is going to be referenced across, however many different laboratories. So we took that on, and found there were some things to be outdated, and needed to be tweaked a little bit, and that was where we really put a lot of thought into how do we guide people to work up these wildly complicated and um, diverse types of wounds. And so I'll just start by saying there's a huge absence, or a big absence of data to guide some of this. And we try to be transparent about where the data is, and where you use this sort of expert opinion that merges with a little bit of practical reality. So let's just start with, high level. We try to stratify in these wound procedures between truly sterile specimens. And that's a whole other conversation as to what a truly sterile specimen ought to be, and is, versus something that maybe isn't non-sterile. And so we did stratify the number of organisms that we'd work up. It would be 3 organisms for something that would be considered sterile, maybe a tissue, maybe a biopsy of some kind, even though that's a little murky also, versus something that's non-sterile where you'd work up 2 organisms there. We went looking hard for evidence to guide that in any kind of meaningful way. There is none. We made it up. So I just want to be transparent about that. And so that speaks to the challenge then with these kind of cultures, because you look at just the mess that is the microbiology for some. They look like stool cultures sometimes, and so you're faced with cultures. We can get to that in some of the examples that have multiple different organisms, from intestinal flora, plus a Staph aureus, plus an Anaerococcus, plus some anaerobes. And so what we went with is we reverted back to, and we looked hard for evidence for these to support this, but we went back to sort of classic teachings in microbiology, looking for a clear predominance of, potential pathogens. And there's precious few obligate pathogens. That's something we also spent a little time thinking about. It's not quite so relevant to diabetic feet, but there's certain pathogens that you would never want to miss. in a wound, Vibrio, anthrax, things like that that you want to make sure you would never miss. But it's also not practical, now that we have MALDI, to identify every single organism in a culture just to make sure you didn't miss an anthrax. And so, we did take some effort to make comments around those kinds of things. Say, well, you don't need to worry that you're missing anthrax because you didn't MALDI every single colony type amongst skin flora. If it's anthrax, it's going to be anthrax and it's going to be loaded with it. You're not going to miss it. It's going to be obvious. Um, so that's one thing. But then, looking at the diabetic foot specifically, and this actually what we found is that there isn't anything that's terribly specific to diabetic feet in terms of the workup. You're going to see maybe a slightly different epidemiology, and you're more likely to encounter a bunch of different organisms, but the pathogens are the pathogens. So, at the top of the list is Staph aureus and group A strep. Now, you don't see a lot of group A strep, but those are two pathogens that I think most laboratories will work up in any amount. Pseudomonas gets to be a gray area, and we tried to leave some ambiguity there. We did try not to take a hard stance. I've worked in several different labs, and they all handle Pseudomonas a little differently. Some will say work up any amount of it. Others will say it can be flora. And so we left some ambiguity there. So do what you will with Pseudomonas aeruginosa, and then you've got everything else. So we're not in the Vibrio aeromonas, like those are true wound pathogens, but those really aren't diabetic pathogens. But now you've got your Enterobacterales, you've got your Enterococcus, and you've got Stenotrophomonas and bugs like that. So these are organisms that tend to be really challenging because, in my mind, Enterococcus and Stenotrophomonas are almost non-pathogens, and that's maybe a shocking thing to say because they do cause serious infection when they do end up causing infections. But as pathogens, they don't do a whole lot. Their primary weapon is being antimicrobial resistant. They don't have a lot of virulence factors that they deploy to cause infection, and yet they're often there. And I think those probably are some of the most damaging pathogens in terms of over-reporting because they're so resistant. Treating an Enterococcus or a Steno requires really aggressive therapy that if you didn't have to expose a patient to, you really probably wouldn't want to because we're trying to conserve those antibiotics. And so the way we wrote the procedure is we use careful language, and this was new in that handbook was the terminology pure or predominant. And so we left a little wiggle room in there in terms of what predominant or how many predominant pathogens you would want to work up. But we really felt like that was important because Enterococcus and Steno, I'll pick on them specifically. I think those are overworked up. um, Often they are part of the flora, right there along with your coag-negative staph and your corynebacterium. But at least in our hands, rarely are they a clear predominant pathogen. They're there, and we wanted to leave some room for labs to feel comfortable not reporting those. So you're really looking for those bugs specifically. We don't need to talk about Staph aureus. Everyone's got that figured out. What do you do with a Stenotrophomonas, an Enterococcus, or an E. coli, for example? If they're part of the general milieu, they're flora, and they don't need to be worked up. Now, in our examples in the chapter, we have people calling them out by name specifically. I don't know. I think that's a great idea. There's not a lot of literature to support what I'm about to say, but we all suspect that naming something gets people disproportionately fired up about it causing disease and probably leads to treatment that maybe we didn't intend. And so I'm a little plus minus on whether or not we need to be naming these things, but unless those sort of like lower tier pathogens, and we indicated that by being pure predominant as the indicator for workup, they could probably be mixed as flora there. And I think the thing I would say, big picture about working up these wound cultures, and with diabetics specifically, is we don't need to be afraid of missing or underreporting here. These are probably not true infections in the truest sense of the word in most cases. And spoiler alert, our cultures and the way they've been studied to predict outcome, they basically have no predictive value. And we can talk a little bit about the data around that if you'd like. But when we look at those pathogens, it's okay to mix them in. And there's a few comments that we've developed in our laboratory that I rather like when we get this uncomfortable combination of pathogens that or potential pathogens that are probably flora to say we've ruled out significant growth of true pathogens, which I think is our physicians have ended up liking, and it's comfortable for the lab because at our primary goal is to diagnose disease. It's not to identify every single organism that's there. And so I think with diabetic wounds specifically, it hopefully can set labs a little bit free to lump things in to know that probably these aren't predicting outcome, and probably in most cases they're not true pathogens.
Yeah, and I can definitely see how you mentioned like Stenotrophomonas being over reported and That's something that like in my lab, it always gets reported and worked up. So let's talk about the treatment. I know, like, right. So it's always very interesting when you are right. We're doing the testing, and what are they going to use? And I know you also mentioned levofloxacin. So can you give some examples of antibiotics used to treat these infections?
Yeah, so high level, the severity of the infection drives the kind of antimicrobial therapy you're gonna get. So the less severe infections, those that aren't limb threatening, oral antibiotics are generally okay. As you progress, you usually want either combination therapy, and IV therapy as well, usually. So we started off saying that the circulation for these patients to the wound is pretty poor. And so by extension, you got to have circulation in order to get antibiotic to the wound. And you know, there's some interesting studies that look at what kind of antibiotic penetration you actually get to the wound. Now, I'm expecting as you get into these studies, 'cause I was really interested in this question. What do we know about antibiotics getting there? And you would assume, well, since they're pretty poorly perfused areas, you're not getting much antibiotics. So there's not a ton of literature on this, but there was a levofloxacin study that was done, and this was one where they did, I believe it was biopsies of the ulcer, and what they found surprised me. There's antibiotic there. At least there's levo, and a decent amount. Now, a little difficult to correlate with the MIC. They did look at the organisms that were there, and they looked at outcomes, and the outcomes were okay. So, despite the fact that they were getting antibiotic there, 30% of patients still failed therapy. So, kind of an interesting finding. They also looked at it with the tetracyclines, which get pretty good tissue penetration. They looked at it tigecycline and omadacycline as well. And this was an interesting study. I don't know who's signing up for this study, but they did a kind of an interesting thing. They biopsied the wound, and they also did a biopsy of an uninfected area. So I don't know who's signing up to have a chunk taken out of an uninfected area, but they did. And it was really interesting. So they compared the penetration of the tigecycline to the wound into the tissue and found that it was basically the same. And when they compared that to what was circulating in the blood, it was the same as that too. So um, those are the only studies I know that have really looked at this question about is antibiotic getting there, which omits a really important drug category being the beta lactams. I didn't find any data on that, but it does suggest that at least these antibiotics are getting to the site of infection. All right, so that's I think a little bit surprising. Um, when we look at outcomes, we find a really, really high failure rate. Um, so 40 to 80% of patients, depending on how you define failure, that are treated with culture guided microbiology results fail therapy. So that's a huge number. That's way more than is acceptable. Um, and so that's a baseline. The folks that did that next generation sequencing study I mentioned also did some outcome analyses, and they found more or less the same thing, but they also found that there wasn't really any difference between the severity of the wound infection, which is sort of interesting. So the mild infections failed just as often as the chronic infections. Now that actually surprises me a little bit. Now knowing that those mild infections are the ones that are more likely to have a single pathogen, which I think of as like sort of the true wound infection, those failed more or less the same amount um, as the more severe infections there. And the one study that I think is really informative, that really maybe speaks to, unfortunately, the lack of importance of culture in predicting anything, is it was a really neat study. Let me see if I can find it in my notes here. It was, yeah, here we go. They looked at it was published in Open Forum of Infectious Disease by a group led by Schmidt. And so they looked at empiric antibiotics versus culture guided antibiotics and looked at the outcomes in these patients. About 120 patients, pretty good distribution of mild, moderate, severe infections, skewed a little bit more towards mild. And they looked at culture guided outcomes and empiric guided outcomes. No difference in outcomes. The only place where they found a little bit of a difference was in whether or not patients were hospitalized. You were slightly less likely to be hospitalized if you had culture guided therapy. So a pretty soft difference there. And what was a little bit counterintuitive with that result is the difference was skewed more towards the mild infections than the moderate or severe infections. So it's almost like a little bit of a conundrum in that finding there. So I found it really interesting that in a reasonably sized study, they didn't find any difference in outcomes based on whether you used empiric therapy or culture guided therapy, which really brings into question, sort of unfortunately our utility in the whole treatment cascade.
I really like this, and I like how you mentioned when you're talking about the guidelines for the cultures, and because that's something that's always it can could cause like a lot of confusion in the lab, and you see like you talk about studies, how difficult it is to come up with guidelines like that. And I know that sometimes techs get it very focused on, well, what's in the SOP and what does it say, or I don't want to miss this, I don't want to underreport this, I have this fear of doing this or that. So yeah, I really like that you mentioned, gave us more light on this subject.
You mind if I interject one other thing, just related to guidelines? Because I think this is also informative and hopefully can lower the anxiety a little bit about these cultures and missing things. So the IDSA, sort of the pinnacle of guidance in infectious diseases, their language around the guidance for doing a culture is, I think, informative. So one of the things they say here, I'll just quote, say, in a person with suspected soft tissue diabetic foot infection, consider a sample for culture to determine the causative microorganism. I find the word consider very, very interesting there, because I think that very strongly suggests that culture is of limited utility, certainly not of broad utility for all wound infections. So I think that's fairly important. They also say consider a duration of 3 weeks of antibiotic therapy for minor amputation with patients with osteomyelitis and a positive bone margin. So in patients that are being treated secondary to amputation, they really do prefer sort of that biopsy from a clean margin. So again, don't send us toes and and feet. So I think that's informative.
Yeah, no, I completely agree. So I know that let's just switch gears a little bit, and I know that you talk about something, the microbiology question of the day. So what is that?
Yeah. So this is something I'm quite proud of, actually. Thank you for asking. So it's something that my buddy and I sort of co-founded. Dr. Carrie Ann Burnham, when she and I were co-fellows at WashU, and we were studying for our boards, or when I was studying for my boards, she helped me out. She was my senior fellow in sending me questions, and I would send her answers with a little bit of a justification. Being terrified of just answering and being wrong, I wanted to justify myself, and so this went on for a little while, and other people caught on to what we were doing, and said, "Hey, can we play along too?" And so it started as just a little email chain, eventually grew into what we called the question of the day. And so early on, it was she and I. Later, Marc Couturier joined us, and it was a weekly or a couple times a week. We would send out questions, and people would answer. And when they answer, we would then provide a discussion around that. It ended up we had a website which was wonderful. A really brilliant pathologist who went to Harvard for a little while developed a website for us. It would allow you to ask and answer questions, and then we provide our feedback. And there was even a comment section. Learned a whole lot from the comment section. Generally speaking, very positive, but anonymous people on the internet can be mean. Uh, so I'm sure you probably know this, although I'm sure all your feedback is positive because this is a wonderful podcast. But we had a heck of a lot of fun. It would keep score for you. Unfortunately, we all got busy, and the website kind of went belly up. And but we're left with this um, cache or this treasure trove of questions that I've kind of gone back to recently, and am trying to polish them up and update them. We've got thousands of questions that myself, Carrie Ann, and Mark wrote, along with a bunch of other submitters. And so I'm trying to get this going again because it was one of the most fun things I think I've done in my career. By the time we were at our peak, we had something like, I don't know, 6,000 subscribers from over 60 countries and all 50 states. It was awesome. So we're trying to dust that off again. I'm looking to get the website fired up again, trying to find somebody to partner with there. So right now we're just doing it as an email listserv, and I've kind of taken a step back to curate all these questions and get them going. So um, happy to get emails if you want to be added to that listserv. We very quickly blew up our email listserv at WashU as it got too big. But if folks want to email me at christopher.dorn at vcuhealth.org, um, I can add you to the list. Right now, it's just sort of a distribution, but we are trying to get it going again, and it's just a fun way to learn. These are 5-10 minute engagements max, and it's a great way to disseminate information and to share information or ideas with colleagues. So yeah, I appreciate you asking. It's a lot of fun.
No, that is great, and I'll put the email on the show notes if people want to reach out. But and when you get it going, you're more than welcome to come in here and do an episode and talk about it more. And
I'd love that.
yeah, no, and yeah, no, and then you mentioned Carrie Ann, she's wonderful, and I said this before. Actually, I last week's episode was she was a guest, and I did it on micro. Very wonderful last minute the guest that I had. they couldn't attend ASM, and I saw her and I asked her, and she's like, "Yeah." So gave her the time. She sat with me, and we recorded an episode. So it was great.
She's the best. I wish she'd have told me I was following Carrie Ann, though. I might have tried to delay it a little bit. I hope there's a podcast or 2 between me and her, 'cause I that's not a comparison I'm looking to make.
That's just the way that it worked out, and one thing that, as you mentioned, yeah, I do get a lot of positive feedback. The negative is minimum, but that is one thing. That and I was doing a presentation on microbe, and when you're in this type of medium and you have to be right, you're putting yourself out there, and anyone with a phone can make a comment. So you just have to kind of don't engage them, don't let them go. If I get positive feedback, I just hit likes and thank you and stuff like that. But if it's something negative, just let them express, what they have to say, and then we move on.
Well, I do have to say, kudos to you for doing this. This is such a wonderful medium that we need to be taking advantage of. What you're doing here is fantastic. I will say it was truly helpful. We started off by talking a little bit about Quizbusters, I think before we turned on the mics here, and or Battle of the Brains. And I used your podcast. I was binging. I'll admit, I was cramming for this, and I used a bunch of your podcasts to help study for that. So I appreciate that.
Oh, thank you so much. Yeah, no, I appreciate it. It's always good to hear the feedback, and I've been going for 4 years now, so I love it. So I always love asking this question because I get all sorts of different answers, but we do have we have that organism that we kind of like for any reason, right? It's either you can have anything for smell, morphology, mechanism, maybe it has a sentimental value that someone did a publication on it. So, what is your favorite organism?
Oh, yeah. So this is easy for me, and if you were to ask my lab, they would all give you the same answer. It's group A strep, which may seem sort of vanilla and boring. It is the one that I did my PhD on. So there's that. I got my start with it early, but I find it to be a fascinating organism. All apologies to Staph aureus, but it probably causes a wider variety of diseases than any other pathogen, which I find fascinating. And having dug deep into the genetics of it, it makes sense. It's got a wildly complex array of virulence factors. It makes something akin to snake venom, all kinds of interesting regulatory machinery. I mean, obviously, there's the post-infectious sequelae, the awful necrotizing fasciitis style infections, and strep throat. And so it does all these wild things. There's even associations, as most of the audience probably knows, with um, some developmental issues like OCD and tics and Tourette's syndrome, which are a little bit controversial, but still just a really interesting pathogen. And then yet, despite all of the antibiotics this has seen throughout its existence, it remains uniformly susceptible to penicillin, which I also find remarkable. On the one hand, you have this pathogen capable of so many different things, except becoming antimicrobial resistant. So it's a really interesting conundrum there. So yeah, easily my favorite organism. Fascinating bug.
I love it. And I think someone that I had at one point in time that was theirs too. But I love the why is it your favorite, your explanation, and it is fascinating, right? When you say about like that's one thing, the antimicrobial resistance, and it can do all these things, but that it can do, it can cause all this and that, but at the same time, it's antimicrobial resistance is not one of the problems with it. So I love that. Um, so is there anything else that you want to add about this, about the cultures or anything at all?
Yeah, I think just to put a little color to the guideline that we put together for the Clean Micro Handbook, because it really is challenging. It's easy to have a protocol and feel strongly about what you do in your own laboratory. It really is a very different matter to try and put something out there that makes sense for everyone. And all of our environments are different. And so I would just encourage people to look at these guys, any of those documents that are in the Clean Micro Procedures Handbook, and think of them as guidelines for what you're going to do in your lab. But you got to make things specific to your own environment there. That was really, it was really eye opening to go through and once you think about, well, yeah, this is what we do here, but is that right for someone who doesn't see a complex patient population or someone that's more complex than us? So that's one. I would say just put your own spin on these things. Talk to your colleagues. That can be a very rewarding thing. For the microbiology lab to get involved with your colleagues. I'm actually in active conversations related to this very conversation with our ID group about developing a diabetic wound specific culture, something where we can drive specimen collection a little bit better than our general wound order. Maybe if we get that going, maybe that's something we can talk about down the road and see if that that ends up working out. But I want to develop some diabetic wound specific comments so we can say, hey, this is what works for us in our lab. This is what we want to communicate to our clinicians. And I think the more nuance, the better there. But having those conversations is the best part about what we get to do, I think. And then the last thing I'll say is specifically related with this culture, but it applies other places too, like some of our really challenging urine cultures or respiratory cultures, is our job is to diagnose disease. And it's often very difficult to know that line between when we're doing too much or too little. We do too much. We do that quite often, and we're just really bad at quantifying the damage we do with that. But I think that's real. The amount of times that we overdiagnose somebody with someone and they get an antibiotic they didn't need is not zero harm. And so I think we feel real good about it. It's very easy to feel good about, well, we didn't miss anything. And so there we go, job done. And there's damage to that too, that I don't want to add any more anxiety or stress to the lab. But I wanted to mention that only because I think it can help us feel better in those times where we're like, and we know in our gut, like we got a whole bunch of flora there, nothing's predominant. You've got all these different bugs. Probably that's a mixed type of thing. It maybe doesn't warrant treating every single one of those things. And the last thing I'll say with that too, and I didn't mention it earlier, is our cultures are unfortunately missing a lot of things. That's the other thing that came out of this NGS study. And so when we get these really polymicrobial cultures, in some ways we're being misleading because there's lots of things that we didn't grow. And so sometimes the most accurate thing is to lump it in and say, hey, this resembles intestinal flora, which paints the picture that we want to paint. Because you can probably steer people astray by identifying just a certain number of things, knowing that there's 10 other things, for example, that aren't being grown. So
Excellent, thank you. Yeah, I can definitely see how we can over-report things and overwork things, and then those things lead to maybe then requests for additional antibiotics, and then from there it gets messy really quick. Well, Dr. Doern, thank you so much for this has been so great, and all the information you gave us, and at the same time, you talk about the clinical microbiology procedures handbook. So thank you for taking the time to be in Let's Talk Micro.
a real pleasure. And again, thank you so much for what you're doing here. I think this is a wonderful forum that reaches a lot of different people. And I don't know if what I said will be helpful, but I know a bunch of your other podcasts are really, really useful. So kudos to you. I hope you are able to keep going.
I appreciate it. Yeah. I plan on doing this for a long time. Thank you so much.
Good deal. Take care.
Well, there you have it. I hope you enjoyed it. It's such a great topic, and I enjoyed talking to Dr. Doern, and I enjoyed, his favorite book and the explanation he gave about it. So it was such a great episode. And something of note is that this is the last episode of season 4, like the last new episode. And those of you that listen, that this is something that we normally do here in the podcast. So typically around July, the season wraps up, and last year there was like some reruns during July, and then we return in August. And this is, it gives us a chance to make new content, and at the same time, typically in July, with people off school and traveling and things like that, normally not that many people listen. So what you might see is maybe an older episode replaying. So stay tuned. Whenever I'm getting ready to publish new content, I will let you know. But I hope you enjoy your summer, whether if you're in school, hanging there, if you're off, taking some time, I hope you enjoy it. If you're working, continue working. But as always, I appreciate all your support, and it has been such a great season. And stay tuned for great content coming your way. As always, you can find Let's Talk Micro on all the podcast platforms like Apple, Spotify, Amazon Music, Good Pods. So I invite you to subscribe to the podcast, download episodes, and if the app allows you to do so, please go ahead and leave a review. As far as socials, you can find us on Blue Sky Social, Instagram, TikTok, and YouTube as Let's Talk Micro, on X as Let's Talk Micro 1, on LinkedIn as Luis Plaza. I am also on Facebook as Let's Talk Micro, and I have an email address, which is letstalkmicro@outlook.com. So either via social media or via email, you can reach out with any feedback, any suggestions. They are always welcome and appreciated. And as you know, the Let's Talk Micro podcast does not have any sponsors, so if you want to support us in any way, you can do so via a Venmo link or via Buy Me a Coffee, KOFI, both links available on the show notes. And if you are looking to learn more about antibiotics, please check out www.learnantibiotics.com and the Learn Antibiotics book available on Amazon. These resources include cheat sheets, practice tests, games, and more. and they are being used by thousands of people worldwide and may be helpful for you or your colleagues. As always, these are some great resources from Dr. Timothy Gauthier, a very passionate pharmacist. And the Let's Talk Micro podcast is supported by the American Society for Microbiology. To learn more about microbes, visit asm.org. And that, my dear audience, is the end of this episode. That's a great wrap to season 4. Wow, I can't believe it. Let's Talk Micro turned 4 in May of this year. 4 years bringing you great content, meeting great people, such a great experience. So thank you so much for the support. Stay tuned, great things coming your way. So we're just taking a break to work on new content, so you might see some reruns, but we'll return with some of that good stuff. So please continue bringing that passion to what you do. It is so important. You do such great work. So, as always, stay motivated, stay safe, and of course, continue talking micro. Until the next time, bye.